stars in the sky, IOL.
So what are glistenings? So glistenings are fluid microvacuoles in the intraocular lens optic viewed on slit lamp biomicroscopy. They form within the IOL matrix under aqueous environment. Glistenings observed clinically are usually 1 to 20 micrometers in diameter. They are more commonly seen with hydrophobic acrylic IOLs but can also be seen in optics made up of PMMA, silicon and hydrophilic material. So what are the theories behind the glistening formation? One is that the polymers used for the manufacturing of the IOLs, they have different components including different monomers, chromophores and cross-linking agents. Microvoids can be found within the network of polymers depending upon their architectural structure. Water permeates these microchannels of the IOL and form minute accumulations inside the microvoids. Second theory is there are relatively slow moving hydrophilic impurities within the IOL which get segregated into cavities, and an osmotic pressure difference between the cavity and the external media in which the IOL is immersed leads to the growth of the cavity and hence the appearance of the glistening. There are several contributing factors also which can affect the degree of IOL glistenings like IOL optic material, manufacturing technique, IOL packaging and changes in the temperature. Associate ocular conditions like glaucoma or those leading to the breakdown of the blood aqueous barrier like diabetes and uveitis, use of anti-inflammatory eye drops containing a surfactant and anti-glaucoma medication may also contribute to glistening formation. What is the impact on the visual function? The impact of the glistenings on the postoperative visual outcome and their evolution during the late postoperative period remains controversial. Some studies show that there is no relevant impact of glistening on the vision, while others have reported an impact on the visual acuity and contrast sensitivity at high spatial frequency, at that only 2 in cases where there is severe amount of glistening formation. So I will present a case report. A 58-year-old lady presented with the complaint of hazy vision, especially in dim light, along with increased glare at night in the right eye since 4 years, which was progressive in nature. The patient reported that her vision was not clear even with glasses. She had undergone cataract surgery elsewhere 7 years back. On examination, her best visual acuity in the right eye was 6 by 12, which was best corrected to 6/9, and in the left eye, she had best corrected visual acuity of 6 by 6. On an examination, the lid margins, cornea, optic nerve, and fundus, they were all normal, and the three-piece IOL was seen well centered within the capsular bag, and the substance of the lens showed multiple refractile glittering inclusions or glistenings that resembled a field of star on a dark night. So these are the slides which show glistenings at different three images we can see, and this slide shows the comparison or the resemblance of the glistenings to the stars in the night. So that gave me the title for the presentation, that glistenings are akin to stars in the sky. So coming to the discussion now, so glistenings are fluid microvacuoles that form within the IOL optic when the IOL is in an aqueous environment. Although they are largely described in association with hydrophobic acrylic IOLs, they can be seen with other materials too. Although several studies have been published on glistening, the impact of this phenomena on visual function is not completely understood. Some studies showed that glistenings reach their peak in number within a few months of formation, showing no further increase thereafter. Other studies showed they progress over time. So in conclusion, in a pseudophakic patient with good Snellen acuity who is complaining of a poor quality of vision, lens glistening should be high or on a different diagnosis list. So these are my references. Thank you. Thank you, ma'am. Thank you, ma'am.
Okay.
Good afternoon to all the dignitaries and all the delegates. I am presenting a case report of a sudden dislocation of PCIOL with unknown reasons. So coming to the introductory part, posterior chamber IOL subluxation or the dislocation is a very rare complication after the cataract surgery, which is only about 0.1 to 0.2% even after the cataract surgeries of 25 years. As we know, it is of early and late type. The late IOL dislocation is mostly of in the back type, whereas out of the back dislocation is rare and is found only in 12.1% of the cases. The predisposing factors are most commonly the pseudoexfoliation or any previous vitreoretinal surgeries, axial myopia, uveitis, retinitis pigmentosa, or any connective tissue disorders. The zonular instability is the final common leading cause, which is leading to within the back dislocations. So a 60-year-old male came to us with the chief complaints of sudden painless diminution of vision in the left eye for 2 hours. There was no history of trauma to the patient. He had a history of cataract surgeries in both the eyes 10 years back. He was a known case of diabetes since 15 years. So we performed the detailed ophthalmic examinations. On the general examination, the patient was well conscious, well oriented with the normal vitals. On ocular examination, his visual acuity in the right eye was 20/60, and in the left eye it was finger counting at 1 meter. When the BCVA was performed, the visual acuity in the right eye was 20/20, and in the left eye it was 20/30. That was with the aphakic corrections. On torchlight examinations, his adnexa, extraocular movements, cornea, anterior, and were within normal limits. The anterior chamber was irregular in the affected eye, and pupil was normal in shape and normal reactive to the pupil light. On coming to the slit lamp examinations, in the left eye, he was aphakic. The posterior capsule was ruptured. A free floating posterior chamber IOL was present floating in the vitreous. Fundal glow was present, and the macula and the peripheral retinas were within the normal limits. There were no evidence of pseudoexfoliation in the patient. These are the photographs showing a rupture of the posterior capsule with a lens floating in the vitreous. This is a very small video in which a free floating lens is being visible in the vitreous and with the posterior capsule rupture. Then the patient was managed with the pars plana vitrectomy and the IOL was explanted. The secondary IOL was placed with the transscleral fixating sutures. Post-operative follow-up was uneventful, and after the 1 month of the surgery, his west corrected visual acuity was 20/30. So coming to the discussion part, as we know, most of the previous studies previously have told that the spontaneous in the bag IOL dislocation is most commonly because of the pseudoexfoliations. It is also hypothesized that myopic eyes are also prone to the zonular failure due to the excessive elongations of the zonular fibers. Although we cannot appreciate any etiologies behind the sudden dislocation of the IOL in this patient, as per the available studies, only aging and the diabetes can be attributed as the probable cause of sudden dislocation of IOL in my patient. However, we need further investigations to rule out the cause in the above patient. So in the concluding slides, I must say that during the phacoemulsification, caution should be given to keeping the integrity of the zonules intact, and particular attention should be paid while implanting a posterior chamber IOL in the capsular bag in eyes who have a weakened zonules. These are my references. Thank you.
Thank you very much. Thanks. You want to pronounce the third one?
Yeah. Third. Dr. Kinjal Shah.
Is absent.
Dr. Kinjal Shah?
Absent.
Absent. Okay.
Next. Nupur.
Dr. Nupur. Pseudophakic bullous keratopathy.
Absent.
Dr. Fatima. Case series of scleral fixated subluxated bag IOL complex. Management and its long-term outcome.
Good morning, everyone. This is about long-term outcome of scleral fixation of subluxated IOL. There are multiple reasons for subluxation of bag IOL complex, and among that, pseudoexfoliation is the commonest cause. Among the several techniques described, we adopted the one described by Oshika T early in 1997, which was minimally invasive in situ fixation. So the aim is to analyze the outcomes with multiple types of IOL. It is a retrospective interventional case series, and consecutive patients who underwent scleral suture fixation of subluxated complex using this technique were included, and data of these patients were analyzed in terms of best corrected visual acuity, IOL centration, ocular residual astigmatism, and postoperative complication. Actually, the technique is passing two arms of non-absorbable suture, one over the haptic and one under the haptic, and retrieving out through the ciliary sulcus and tying it over the sclera. Here the knot is buried. We have modified to bury the knot by making a Hoffman pocket, and here it is an anterior subluxation of dual haptic IOL or foldable IOL, where the needle is being passed in between the gap of the dual haptic, and it is retrieved out through paracentesis. And after taking it out, the needle is reversed, and again now the IOL is positioned under iris, and the cannula is inserted from outside in. Now the needle is reversed and passed above the level of haptic and retrieved out, and now the knot is sutures will be retrieved out from this Hoffman pocket, and suture will lie safely in the Hoffman pocket. With the help of one paracentesis, minimally invasive centration was obtained. And similarly, other cases where there is posterior subluxation, for good visibility we apply iris hook, and the same method is followed. And there were 13 eyes of 13 patients, and mean standard deviation of age is 68.6 years, and there was majority was male patients and the majority was right eye. Axial length was 23.92 millimeter, mean axial length. Average follow-up was 42.54 months, that is around 3 to 4 years, and longest follow-up was 87 months, more than 7 years. Best corrected visual acuity improved from preoperative status 0.47 to 0.22, and all the cases maintained good IOL centration except one case, but this is not a decentration, this was a decentered fixation. It happened to be an iris coloboma case, so it was left undisturbed. And ocular residual astigmatism was calculated in terms of J0 and J45. In both the axes, it was minus 0.55 and minus 0.17 respectively, so indicating there is no major astigmatism due to IOL per se. And post-operative complication, one patient had cystoid macular edema, but it was present pre-operatively, pre-scleral fixation, and 3 patients needed AIOC capsulotomy. This is the profile of the patients, where we can see the multiple different types of IOL, rigid, hydrophilic, hydrophobic, and some with CTR. There are various techniques described in literature. This is one technique where the haptic is externalized through paracentesis and suture is made. Again, it needs manipulation of taking out the haptic from the bag. And here is a technique where the fixation is done along the fibrotic margin. And this another technique, this another paper, similar fixation was done, but the follow-up is 9.1 months. So in our study, we feel minimally invasive in situ fixation, it's good outcome, long-term outcome. Thank you.
Thank you.
Next, Dr. Alankrita Hajarika. Unilateral ocular myiasis.
Good afternoon, respected judges, on all the delegates of AIOC 2022. Myself, Dr. Alankrita Hajarika, postgraduate trainee from Assam Medical College and Hospital. The topic of my today's presentation is unilateral ocular myiasis. It is co-authored by Dr. Paramiz Farali and Dr. Dipanjan Ghosh. So starting with the introduction, Maya is a Greek word meaning fly. Ocular myiasis is a condition caused by infestation of ocular and acnet cell tissue by fly larvae. It progresses rapidly, destroying all the orbital and periorbital tissues, along with bony erosions leading to intracranial extension. So my case is a 25-year-old emaciated female presented with blood mixed teachers from right eye for 15 days. pain in the same eye for 15 days and foreign body sensation for 10 days. She is also a known case of psychiatric illness with a habit of forgetfulness which landed her up in a swampy area, later rescued by the localites 2 weeks after her missing complaint was lodged. So in general examination, the patient was not oriented to time, place and person. Her weight and nutrition was poor, vitals were stable except that her BP was low. She was found in an afebrile state and ulceration was present in the right thumb. So coming to the local examination of the right eye, ulceration and maggots were seen in both the lids of the right eye. Conjunctiva was grossly chemosed. Ulceration and necrosis was seen more in the palpable conjunctiva parts along with some hemorrhagic spots. However, the cornea was clear, pupil was round, regular, reacting to light. Visual acuity and extraocular movements could not be assessed at that time as the patient was not oriented. Left eye findings, periorbital swelling was found. So this is a clinical presentation of the patient at the time. So coming to the hematological investigations, RE blood was deranged with low hemoglobin, high total count. ESR was also high. Serum electrolytes was also deranged with low level of sodium and low level of potassium. Urea was high and creatine was within the normal limits. Total protein was low. Albumin and globulin was low. And coming to microbiological parameters, viral markers were non-reactive and entomological evaluation revealed that the larvae were the species of Chrysomia vagina. And in radiological investigation, right-sided preseptal swelling can be seen. So a multidisciplinary approach was made consisting of the ophthalmologist, physician and the psychiatrist. Mechanical removal of the maggots with forceps and turpentine oil was done under local anesthesia. Mechanical debridement of the ulcerated area was done under local anesthesia. Infiltration of the wound with 10% provident iodine was done. Dressing was done with high ointment moxifloxacin. Initially, it was done 3 times daily for 3 days, and then it was done twice daily till when the patient was discharged. So, systemic treatment includes a single dose of tetanus toxoid injection, piperacillin and tazobactam 4.5 gram TDS daily for 7 days was given, along with infusion metronidazole and iron sucrose. Ivermectin was given, and anti-inflammatory and vitamin C was given as an adjuvant therapy. So the results, the patient got oriented to the surrounding from the 3rd day onwards. Wound was free of larvae from the 4th day. Edema subsided gradually from 6th day onwards. Fresh granulation tissues appeared simultaneously. Serum electrolytes returned to a normal within a week later. The patient was discharged on 9th day. Visual acuity at the time of discharge was 6/9 on both the eye. Complete resolution of edema was seen after 2 weeks of follow-up, and the wound healed by secondary intention. So this is a picture of the patient on the 1st day, 3rd day, 9th day and 18th day respectively. So coming to the discussion part, orbital involvement occurs in 5% of all the myiasis cases. It is predominantly present in tropical and subtropical region with warm weather. Chronic debilitating conditions like leprosy, diabetes mellitus, open wound, fungating carcinoma, psychiatric illness, intellectual disabilities, poor hygienic condition may predispose the individuals with myiasis. Infestation with Chrysomia vagina differs from usual maggot infestations as it can infect the tissues without pre-existing necrotic tissue and cause extensive damage to the living tissue if left untreated. Vision is usually restored if treatment is done in early stages. Successful treatment of myiasis depends upon the stage of presentation, severity and associated predisposing conditions. So these are my references, and thank you for patient listening.
Thanks. Nice. Call.
Mihika Dubey.
Absent.
Rani Bhattacharya. And marks won't be given as you are not a ratified member, right? You can present.
A very warm good afternoon to respected dignitaries and the delegates. I welcome you all to my presentation on sequelae of vitamin A deficiency, a case report. I am a postgraduate resident from Rio GMCH. So on introduction, vitamin A deficiency is an important cause of nutritional blindness in young children and causes more than 250,000 children to go blind in Asia each year, of which 52,500 cases per year are from India. Vitamin A deficiency also leads to retarded growth and development, decreased immunity, and increased child morbidity and mortality. Although on the national immunization schedule, vitamin A supplementation is mandatory, around 1/3 of children are not receiving the required dose. So a 10-year-old female presented to us with gradual, progressive diminution of vision with whitish discoloration of the cornea, both eyes, since the last 2 years, which gradually she presented with pain since the last 2 weeks of the left eye. There was no history of redness, discharge, trauma, or any ocular illness in the past. She is a patient who suffers from chronic diarrhea and was treated by a local herb practitioner. There is no history of similar illness in the family. Her birth and developmental history were uneventful. She was exclusively breastfed up to the age of 2 months and has incomplete immunization. Her family belongs to lower socioeconomic strata. So on local examination, the positive findings were adherent leukomatous opacity centrally covering the pupillary area of the right eye, and in the left eye there was increased interpalpebral aperture and a corneal scar with scleromalacia and impending staphyloma superiorly with superficial vascularization. In the iris, we see an adherent iris tissue to the cornea at 3 o'clock position. The pupil was irregular and was of around size 3 millimeter. Only direct light reflex was positive. The visual acuity of the right eye was hand movement, which did not improve with pinhole or best corrected visual acuity. And in the left eye, it was PL negative, and extraocular movement was diminished in all directions and was painful. And the intraocular tension of the left eye was digitally hard. Rest of the anterior segment appeared to be normal. Ultra USG B scan of the right eye was within normal limits, and the left eye in the left eye it was avoided as the patient was in pain, and also there was impending staphyloma. On general examination, the child was alert, awake, comfortable, and assuming a decubitus of choice. She was thin-built and cachectic. The vitals were within normal limit. On anthropometry examination, her height was around 120 centimeter, weight was around 24 kg, which was, both of them were below -3 standard deviation, and her BMI was around 16.7, which is also less than -3 standard deviation. On general examination, we could find pallor. The oral cavity, tongue was pale and smooth. Angular stomatitis and cheilitis was present. Teeth and gums were unhealthy. The skin and appendages, it was dry, lustreless, and scaly skin. Limbs, there was mild muscle wasting present. On routine hematological examination, routine blood was within normal limit, but her hemoglobin level was 5.2 gram per deciliter. Her iron profile was low, and peripheral blood smear showed hypochromic hypovolemic anemia, and her serum retinol levels were 0.45 micromoles per liter. So we came to the provisional diagnosis of grade X3 xerophthalmia, grade X3A on the right eye, and grade XS with scleromalacia and severe acute malnutrition of the left eye. Management was started with vitamin A capsule, which is as recommended by the Government of India, WHO protocol, 2 lakh international units on day 1, then followed by 2 lakh international units on day 2, followed by 2 lakh international units on day 14. Eye drop hydroxypropyl methylcellulose of 0.7% was started for 1 drop 4 times daily, and a multivitamin dose was given. So our patient presented with painful blind eye with impending staphyloma, due to which enucleation of the left eye was done after proper consent, so that further progression of the disease could not occur, and to maintain cosmesis. Her right eye is planned for penetrating keratoplasty and registered for the same. She was referred to the pediatrics department for further management and was started on fortified food. Patient is on follow-up. Coming to discussion, so we report a case of late-stage xerophthalmia with severe acute malnutrition. Diagnosis of vitamin A deficiency in a tertiary care hospital at such a late stage is very rare and unwanted. Our patient had not been diagnosed anywhere, although she had been presenting since the last 2 years, and leaving her with permanent visual deficits. So at-risk children, such as those belonging to lower socioeconomic background, decreased breastfeeding, poor weaning, and immunization history, should be referred for prompt ophthalmological review due to risk of permanent visual loss. On conclusion, vitamin A deficiency is a preventable yet leading cause of blindness. Unawareness and ignorance of the general population has to be addressed at an urgent basis, and prompt referral along with door-to-door immunization and vitamin A supplementation by primary healthcare and social workers should be encouraged. These are my references. Thank you.
Thanks.
Dr. Yogya Reddy, malarial retinopathy.
Good afternoon, dignitaries and delegates. I am Dr. Yogya, resident from MGM Hospital, Navi Mumbai. Today's presentation is about. I hope I'm audible. Today's presentation is about a case of malarial retinopathy, which is presented to our OPD. Introduction. Malarial retinopathy was first described by Lamella et al. In 1993. Retinal hemorrhages, sometimes with subhyaloid extension, papilloedema, retinal edema, retinal pallor are the common findings of malarial retinopathy. These fundus findings are an indicator of poor prognosis in critically ill patients. Malarial retinopathy is commoner in fatal, cerebral and severe falciparum malaria. However, it is rarely reported in uncomplicated cases. The most commonly proposed mechanism of pathogenesis is the sequestration of erythrocytes causing retinal changes. The condition is known to be reversible with no permanent damage to the retina. However, retinal nerve fiber thinning is a proposed late complication in few cases. Moving on to the current case, a 21-year-old male patient of falciparum malaria was referred to the ophthalmology OPD in view of red eyes and sudden onset blurring of vision in both eyes for 2 days. It was progressive and painless and occurred in a febrile context. On examination, the patient had a distant visual acuity of 6/24 in the right eye and 6/18 parts in the left eye, and near acuity of N12 in the right eye and N10 in the left eye. And his color vision was normal in both eyes. And on Amsler's grade examination, he had metamorphopsia in both eyes. Extraocular muscular movements were full, free, and painless in both eyes. On anterior segment examination, lids and adnexa were normal in both eyes. Conjunctiva showed subconjunctival hemorrhages on the temporal part of conjunctiva in both eyes, and his intraocular pressure was 18 millimeter mercury in both eyes. This is the anterior segment examination at presentation. Moving on to the posterior segment examination, media was clear in both eyes. Optic disc showed nasally blurred margins, and macula showed subhyaloid hemorrhage in both eyes. Foveal reflex was normal and blood vessels appeared normal, and on peripheral fundus examination revealed retinal hemorrhages and multiple rod spots in both eyes. OCT was done for the patient, which revealed hyporeflectivity at multiple layers with fluid accumulation at macular area suggestive of intraretinal and pre-retinal hemorrhages along with subhyaloid extension at the macula. And few blood investigations were conducted which revealed the peripheral blood smear showed a Plasmodium falciparum parasite, and his complete blood picture was normal. So a provisional diagnosis of malarial retinopathy was made. Intervention: the patient was treated with systemic artesunate and doxycycline along with some vitamin supplements. Patient was followed up regularly with nil ophthalmic intervention. On first follow-up after 5 days, his visual acuity improved to 6/9 in both eyes, and there was a complete resolution of hemorrhages and significant reduction of rod spots and disc edema in both eyes. On follow-up after 2 weeks, his visual acuity drastically improved to 6/6 in both eyes, and also Amsler's grid test was normal with no metamorphopsia, and both eyes anterior and posterior segments appeared normal on slit lamp examination and fundus examination. So these are the pictures of fundus at presentation. The first picture is at presentation, and the second picture is at follow-up after 5 days. And after 2 weeks, patient had completely normal anterior and posterior segment findings. Moving on to the discussion part, the proposed pathogenesis of malarial retinopathy is impaired perfusion, which is likely to be due to the sequestration of infected erythrocytes occurring in retinal microvasculature, which in turn causes hypoxia and ischemia of the retina. The alternate hypothesis for pathogenesis is the release of inflammatory markers from retinal blood vessels. Most common symptoms are retinal hemorrhages at multiple layers, and other findings are disc edema, vessel discoloration, and retinal whitening. Malaria retinopathy is well documented in children by various groups, primarily in Africa and other endemic countries. However, the condition is rarely reported in adults. In a study conducted in India, D.K. Coker stated that 34.1% of cerebral malaria patients were found to have retinopathy-like changes like retinal hemorrhages, blurring of disc margins, retinal edema, and disc pallor, and also hard exudates. Lorenzen et al. Noticed retinal hemorrhages in 14% of patients with cerebral malaria in a study conducted in Thailand. Although the above studies show that retinopathy is well associated with very severe, complicated or cerebral malaria, its association with uncomplicated cases is very rarely reported. Even though malarial retinopathy is directly related to the severity of systemic disease, the post-recovery outcome of visual acuity is remarkably good. Spontaneous resolution is noted in a majority of cases, including current case. A.M. Dondrop et al. Proposed the use of quinine and levimazole has a role in reducing the sequestration of erythrocytes. The role of artesunate and other agents in the condition is still under study. We treated our patient with systemic artesunate and observed satisfactory results. Moving on to the conclusion part, even though malarial retinopathy appears frightening on the first glance, the prognosis is remarkably good without any need of targeted therapy or intravitreal injections. Malarial retinopathy holds diagnostic importance. Henceforth, it is important to rule out malaria in patients presenting with blurring of vision in febrile context. This case report brings to light the rare entity of malaria retinopathy in an adult case of uncomplicated malaria. Malaria has to be ruled out in patients with fever presenting with sudden blurring of vision and retinal hemorrhages. We wish to stress upon the diagnostic importance of condition in an ophthalmologic point of view. Regardless of the frightening nature of condition, it is important to not overtreat the condition. These are my references. Thank you for the opportunity.
Thanks.
Dr. Bhavna Agarwal, multidisciplinary approach to rare case of cavernous sinus thrombosis.
Good afternoon everyone. I'll be presenting on multidisciplinary approach towards a rare case of cavernous sinus thrombosis with indilated carotid fistula. The cavernous sinus thrombosis is the formation of a blood clot within the cavernous sinus, a cavity at the base of the brain that drains the deoxygenated blood from the brain back to the heart. Basically, it is of two types, septic and the aseptic. It presents with non-specific symptoms like the fever, headache, and ocular complaints like the periorbital swelling and ophthalmoplegia. So its early diagnosis and treatment is critical for a good outcome. There's a case report, a 59-year-old female presented to her OPD with complaint of headache, pain, redness, and gradual protrusion of eyeball in the left eye since 1.5 months. She was known case of hypertension since 3 years and was on medication. There was no history of any ocular trauma, foreign body exposure, or any surgery. On ocular examination, the right eye was within normal limit. The left eye showed the vision was 636 partial and the BCVA was 624 with N36. Extraocular movements was restricted and painless in all gauges. Lid showed edema with axial proptosis. The anterior segment examination, congestion, chemosis with engorged episcleral vessels was seen in the left eye. The AC was shallow with fixed dilated pupil. The IOP was 22 mmHg in the left eye while 17 mmHg in the right eye. The corneal sensations was reduced. This is the image of the left eye of my patient showing congestion, engorged episcleral vessels with fixed dilated pupil while the right eye is absolutely normal. The fundus of the left eye showed splinter hemorrhages inferior to disc and blood vessels were tortuous. Other was within normal limit. The investigation was done. Her MDCT showed the dilatation of the superior ophthalmic vein in the left side with failing defect in left cavernous sinus. Mild left eyeball proptosis was seen with diffuse thickening of extraocular muscles. So it made the diagnostic possibilities of indirect carotid cavernous fistula with left cavernous sinus thrombosis. The MRI was done which showed mild left eyeball proptosis with bilateral maxillary sinusitis, left cavernous sinus thrombophlebitis with left orbital cellitis. The blood investigation was normal except the ESR was raised. She was started on injectable antibiotics ceftriaxone, vancomycin, metronidazole with tablet acetazolamide and tablet clopidogrel was started 75 mg OD. Neurosurgery advice was taken for the same. She was advised moxifloxacin and CMC eye drop in the left eye 4 times per day. On the initiation of treatment, there was decrease in left proptosis and congestion and improved ocular movements in all gauges. In the following week, study improvement was seen. At the time of discharge, her BCVA was improved to 618 and proptosis was nearly resolved with return of full range of ocular movement. She was referred to the neurosurgery department. Complete resolution of congestion and chemosis took further 6 weeks, and the repeat MRI scan was done after 2 months, which was found to be normal. This is the image of the left eye at the time of admission, discharge, and follow-up. At the time of discharge, the complete resolution of symptoms occurs. So what we propose, primarily it was infection of sinus, that the maxillary sinusitis, leading to orbital cellulitis, causing cavernous sinus thrombosis, and finally it giving rise to carotid cavernous fistula. These are abnormal vascular shunts that allow blood to flow from the carotid artery into the cavernous sinus. The intact CCF is because of the rupture of dural branches of the carotid artery weakened by a defect. An alternative theory is seen that increase in the cavernous sinus pressure increases the risk of the tear of the dural arteries, which might be in our case too. And the dural CCF often resolves spontaneously. The mainstay of treatment is early high-dose antibiotic therapy, and the role of anticoagulants is not yet well established. It was found to no reduction in mortality with the use of anticoagulants in cavernous sinus thrombosis. So we are keen to report this case because it is a rare presentation and very few reports of similar cases are present. Early diagnosis and treatment is required for good outcome, and a successful management requires multidisciplinary approach involving the ophthalmologist, neurosurgeon, and the radiologist. These are my references. Thank you.
Dr. Padma Shri Kyama, a rare case presentation of cataract and exudative RD after insect bite.
Good afternoon, everyone. My case is a rare case presentation of cataract and exudative retinal detachment after insect bite. Introduction. Honeybee sting comes under the order Hymenoptera. Ocular features associated with honeybee sting includes conjunctivitis, keratitis, cataract, iritis, involvement of optic nerve and retina. Venom contain melatonin, apamine, formic acid, phospholipase A, hyaluronidase. Venom causes the type 1 hypersensitivity response mediated by the immunoglobulin E. Exudative retinal detachment occurs due to the accumulation of subretinal fluid in the subretinal space that is present in between the retinal pigment epithelium and neurosensory retina in the absence of retinal break and traction. Exudative retinal detachment occurs in vascular, inflammatory and neoplastic diseases involved in the retina, retinal pigment epithelium and choroid. Ocular inflammation also causes the lens opacification. My case report is a 35 years old male came to the hospital with chief complaint of pain and sudden loss of vision in right eye since 3 days. There is a history of insect bite, that is honeybee bite to the right eye 3 days back, and visual acuity in right eye is hand movements and in left eye is 6/6. Anterior segment examination in right eye, there is a insect bite mark is seen inferotemporally, that is 4.5 mm away from the limbus, and there is a conjunctival congestion is present, and anterior subcapsular and posterior subcapsular opacification is there, and left eye is normal. Posterior segment examination, fundus, right eye shows there is a medial opacity due to the anterior and posterior subcapsular cataract and vitreous haziness is there, and optic disc is normal. There is a AV ratio is 2:3 in in superior quadrant. There is a retinal elevation is there in inferiorly. It shows the inferior retinal detachment. Left eye is normal, and USG B scan shows there is a inferior retinal detachment and shifting fluid is present. Discussion. Venom causes the ocular inflammation by increasing the capillary protein permeability, greater leakage of protein into the extravascular space, reduces the colloid osmotic absorptive force across the capillary walls, that is favoring the extravascular fluid retention, lead to the exudative retinal detachment. And there is a metabolism of lens is deranged due to the diffusion of toxins released in the ocular fluid. Due to inflammation, it is lead to development of the subcapsular cataract. In my case, patient present with pain and sudden loss of vision in right eye after honeybee bite, and lens shows the anterior and posterior subcapsular cataract and vitreous haziness, and retina shows the greyish white reflex of retinal detachment, and treated the case with topical steroids, that is 1% prednisolone acetate eye drops 6 times per day, and systemic steroids, that is tablet prednisolone 20 milligrams BD, and referred the case to higher centers. And conclusion, honeybee sting causes the acute ocular inflammation. In ocular inflammation, there is a early diagnosis and treatment will improve the outcome of the patient. After 12 weeks of follow-up, all ocular inflammation is subside, and then do the cataract surgery for subcapsular opacification. The post-operative visual acuity was 6/6 with a normal fundus. These are my references. Thank you.
Thanks. Now call upon Dr. Anjali Maheshwari. Unilateral exudative RD with leopard spot retina.
हाँ वो फ्री पेपर का कब है? Yes, yes.
Brahmachari is in hall D at 1:30.
1:30 तो वो मेडिकल रेटिना में था ना मेरा, एक बार चेक करके बताएंगे.
Yes, please.
Good afternoon, everyone. Good afternoon, everyone. Today, I'll be discussing the approach to a case of exudative retinal detachment with leopard spots with the help of a very interesting case and dilemmas we dealt with along with the queries which still remain unanswered. There are no financial disclosure. So the patient is a 63-year-old male, known case of type 2 diabetes mellitus, dyslipidemia and hypertension since past 12 years under treatment. He presented with complaints of gradual onset, painless and progressive diminution of vision since 4 years in both the eyes, the left eye followed by right. There was previously documented history of subretinal fluid and pigment epithelial detachment in both the eyes along with the exudative retinal detachment in left eye. There was a history of undergoing 4 intravitreal anti-VEGF injection in left eye and 2 in right eye over the period of 4 years. His best corrected visual acuity in right eye was 360 and in left eye was 6.9. The anterior segment was within normal limit. He was pseudophakic in both the eyes. The posterior segment showed, the photos were taken by a handheld fundus camera. In the sitting posture, the patient shows an inferiorly elevated retina, and in the supine posture, he had a shifting of the subretinal fluid, which shows almost a subtotal retinal detachment. In the left eye, the retina was attached when he presented to us, but there was a documented detachment in the left eye previously, which settled on its own. And on we did an FFA to rule out any leakages in case of a multifocal CSCR, but we found pigmentary hypertrophy and RPA hypertrophy and a leopard spot retina in both the eyes. The OCT in the right eye was corresponding to the retinal detachment, and it was done in obviously sitting position. And so he underwent a battery of investigation to rule out all the possible causes. The blood investigations, the routine CBC, ESR were normal, within normal limit. The chest X-ray was within normal limit. He also complained of minor difficulty in passing urine, so he underwent a KUB USG which showed a grade 2 prostatomegaly. Then he underwent a prostatic specific antigen which was high at the level of 10.19 nanogram per ml. So we suspected that it's probably a metastasis, and he also underwent a PET scan to see if there are any hyperreflectivity. So in PET scan he showed features which are suggestive of primary prostatic neoplasm with nodal involvement. So he was referred to a surgeon where he underwent a truss biopsy, but he showed no neoplastic growth on histopathological report, and it was found to be an incidental age-related change. He also underwent an MRI to see the scleral thickness, which was 1.5 mm in right eye and 1.2 mm in left eye, which was in normal range. The USG-B scan in right eye showed a retinal detachment, and the UBM showed a choroidal detachment. In the left eye, there was just choroidal thickening with normal retina attached. So the dilemmas were, when the patient presented to us, he already underwent a few intravitreal injections. So the presentation was modified when he presented to us. Secondly, there was documented subretinal detachment and a PED earlier, which responded to an anti-VEGF. The evidence of chronic retinal pigmentary epithelial changes in the left eye was also there. So our first differential was the chronic CSCR of an atypical variant.
The next finding of choroidal detachment on UBM and B scan was found. The scleral thickness was again within normal limit on MRI as well as on UBM. So we shifted our diagnosis to the uveal effusion syndrome. Although the axial length was normal, so we thought it's probably the type 3 variant of uveal effusion syndrome, where the axial length is normal and the thickness is also within normal limits. But we detected a prostatic mass. So our diagnosis again shifted to a metastasis or a paraneoplastic response, and we evaluated him fully for a month with a battery of investigation. Meanwhile, we also gave a therapeutic trial of an anti-VEGF for a pachychoroid or a chronic CSCR spectrum. But no response to anti-VEGF was found, and the prostatic mass detected was also found to be benign. So again, we moved back to the uveal effusion syndrome, but we thought to rule out lymphoma, which was very less likely, but we still thought of doing a ab externo drainage along with subretinal fluid analysis. But during the procedure, there was an induction of an iatrogenic break, and we had to convert the procedure to a PPV with drainage of subretinal fluid and endolaser. Luckily, it worked, and this is the post-operative photograph of the patient after 4 weeks, and his vision improved to 660. He's still under follow-up, and there are no active detachment as of now in either of the eye. So the issues that we still are thinking about was that a pachychoroid with exudation? If yes, then why was there a choroidal detachment? And he also didn't respond to the anti-VEGF we gave. Finally, we came to the diagnosis by exclusion of uveal effusion syndrome type 3, which is a non-anophthalmic eye with normal scleral thickness. Thank you. Lastly, I would like to acknowledge my professor, Dr. H.S. Trehan, for his inputs and support. Thank you.
Dr. Uditi Pankaj.
Bindu Malini.
She is the chief author,
Okay,
but
okay.
presenting is Dr. Uditi. Yeah, please come.
Good afternoon, one and all. I'll be presenting on the study done on assessment of the effect of topical phenylephrine eye drops on blood pressure. As we all know, tropicamide is a parasympathetolytic which, along with phenylephrine, which is a sympathomimetic, is used for the topical application in and out for mydriasis. The topical installation of eye drops reaches the systemic circulation through the cornea, conjunctiva, or by absorption through the nasal mucosa via the lacrimal system. The systemic absorption of phenylephrine causes a pressor response which increases the peripheral vascular resistance, causing an increase in systemic hypertension, reflex bradycardia, arrhythmia, and subconjunctival hemorrhage. But such pressor response is not seen with tropicamide. This was a prospective interventional study which involved 165 adult patients and 10 pediatric patients. The inclusion criteria were patients aged 18 years and above, along with the pediatric age group, and the patients who attended the ophthalmology OPD for routine eye examination. The exclusion criteria were the patients with known ischemic heart disease or any other cardiac illness and a baseline blood pressure of more than 160 millimeters of mercury. The baseline blood pressure was recorded using a manual sphygmomanometer prior to the installation of eye drops. 1 drop of tropicamide with 5% phenylephrine eye drops was instilled every 15 minutes for a total of 60 minutes, and the blood pressure was measured at the end of 30 minutes and 60 minutes. And as the study was conducted in a multi-speciality hospital, a crash cart was available and emergency treatment facilities were at disposal in case of any untoward consequences. There were patients who were with comorbidities were 82 in number, out of which 33 were hypertensives, 21 were type 2 diabetes mellitus, 2 patients were with COPD, 1 patient was hypothyroid, 23 patients were hypertensive along with diabetes, and 1 of each had hypertensive with COPD and hypertension with diabetes and hypothyroidism. Amongst the 83 patients with no comorbidities, the mean systolic blood pressure prior to the installation of eye drops was 120 and post-dilatation was 122. The mean diastolic blood pressure prior to the installation of eye drops was 77 and that post-dilatation was 78. The mean arterial pressure prior to the dilatation was 91 and that post dilatation was 93. Amongst the patient with comorbidities, the mean systolic blood pressure prior to the installation of eye drops was found to be 126 and that post dilatation was 128 with a p-value of less than 0.001, which was statistically significant. And out of the 58 hypertensive patients, 6 patients had an increase in the systolic blood pressure by a mean of 10 millimeters of mercury, and out of these 6 patients, 3 of them had an increase of 30 millimeters of mercury in the systolic blood pressure. The mean diastolic blood pressure prior to the installation of eye drops was found to be 79 and that post dilatation was 80 with a p-value of 0.006, which was again found to be statistically significant. The mean arterial blood pressure prior to the installation of eye drops was 95 and that post dilatation was 96 with a p-value of less than 0.001, which was again statistically significant. Amongst the pediatric age group, which involved the patients from the age group of 5 to 15 years, the mean systolic blood pressure prior to the installation of eye drops was 106 and that post dilatation was 109 with a p-value of 0.009. The diastolic blood pressure was 71 pre-dilatation and post-dilatation was found to be 74 with a p-value of 0.01. And the mean arterial pressure prior to the installation of drops was 83 and that post-dilatation was 85 with a p-value of 0.01. And all these parameters were again found to be statistically significant. So conclusion of the study was out of the 58 hypertensive patients, only 6 patients had an increase in the blood pressure by a mean of 10 millimeters of mercury after the complete pupil dilatation. So thus phenylephrine can be used for topical installation as and when needed. Thank you.
Dr. Himani Pal, comparison of CCT measurement by NCT pachymetry.
Hello, good afternoon everyone. Today I will be presenting paper on comparison of central corneal thickness measurement by non-contact pachymetry and ultrasonic pachymetry. We all know that the measurement of central corneal thickness has a crucial role in both the diagnostic and the therapeutic assessment of ocular pathologies, and it is routinely practiced in our OPDs. Various new techniques have also come for CCT measurement, but in order to know the accuracy of new device or technique, it should be always be compared with a gold standard technique like ultrasonic pachymetry. As CCT has direct influence over the intraocular pressure, and we all know that for every 10 micron meter difference in CCT from the population mean, there is a 0.5 millimeter mercury difference between the actual and the IOP measured with the Goldman applanation tonometry. And true IOP is underestimated in thin corneas and overestimated in the thicker corneas. So the aim of our study was to compare the central corneal thickness measurement between the non-contact pachymeter, Topcon TRK2P and ultrasonic pachymeter. Nowadays non-contact pachymeter is constantly used as it is patient friendly and time saving, but it has not been well documented whether the CCT obtained from it is comparable to those derived from the conventional ultrasonic pachymetry. As very few previous studies has evaluated this device, hence and the results are inconsistent, hence we did this study to prove the reliability of the non-contact pachymeter. So 100 patients ranging from age group 16 years and above were enrolled in the study who came to ophthalmology IOPD, and patients with corneal pathologies, contact lens users, and patients with past history of refractive or any other type of intraocular surgery within the last 3 months were excluded from the study. First, the central corneal thickness was measured with the non-contact pachymeter, and after 10 minutes of taking reading, then with the ultrasonic pachymeter, the CCT was compared under the topical anesthesia, and all the measurements were done by a single observer. So the main age group which we found in our study was of 31 to 45 year age group. There were 43% patients in this age group, and the mean CCT which we found through non-contact pachymeter was 492.54, and through ultrasonic it was 528.37, and the p-value was less than 0.001, so it was significant. So the difference between the two instruments which came was about 35.83, and this showed that there was a significant difference between the CCT measurement between the non-contact method and the conventional ultrasonic pachymeter. that this scatter plot is showing that there was a positive correlation between the two instruments, that if the patient has a lower CCT value through the ultrasonic, then the non-contact pachymeter also showed the similar values. And the limits of agreement between the two instruments was ranging between 24.19 and the 47.04 micron. So there were various other studies also which showed similar results to our studies. For example, Wells et al. Compared the ultrasonic pachymeter with the non-contact pachymeter, and they found there was a difference of 29.7 micron between the CCTs. Similarly, Bovell et al. Also compared the non-contact with ultrasonic, and they found there was 31.6 micrometer difference. In conclusion, we say that there is a slightly higher difference in our study between the non-contact and the ultrasonic pachymeter. It was around 35.83, and the non-contact pachymeter shows slightly thinner values as compared to the ultrasonic pachymeter. Hence, we conclude that the non-contact pachymeter should be cautiously used, as there is slightly difference in the values obtained. Thank you.
Good. Dr. Sameer Dash, entropion-induced blindness.
So Dr. Sameer is probably not here.
Okay, he's not here, absent.
You're Pratik?
Yes, sir.
Oh, okay.
Okay, please start.
Not coming here.
Why not? Let's come. Slides to the यहाँ से हटा हुआ
Yes.
Okay. So thank you. Good morning, chairpersons and dear friends. And this is a case on bilateral pigment epithelial detachments and right central serous chorioretinopathy in a COVID patient. No financial interest to declare. We hereby report a case of pachychoroid spectrum disorder in a patient of COVID and discuss its possible etiology. The patient was a 30-year-old male from Patna, railway official, hospitalized with RT-PCR proven clinically moderate COVID-19 pneumonia. He presented with shortness of breath and fever for 5 days at the time of admission. On the 6th day, he developed acute blurring of vision and color desaturation in the right eye, not associated with pain, distortion of images, or flashes of light. The patient was not a known case of systemic diseases. There were no previous ocular complaints, and there was no history of medication. The family, social, and occupational history were unremarkable, except for a positive travel history 15 days ago. He was being treated while admitted to our COVID ward according to the protocol, and the tablet dexamethasone 6 milligram per oral once daily was started 1 day ago. On examination, the patient was a mild case of COVID with saturation of oxygen 96% and bilateral basal clefts. A bedside examination in the COVID ward showed visual acuity of at least 6 meters and a normal anterior segment examination. The ocular examination at the bedside, the fundus, showed a right central serous chorioretinopathy and bilateral pigment epithelial detachments. So the patient was diagnosed as both eyes pigment epithelial detachment and right central serous chorioretinopathy with mild COVID-19 pneumonia. the differential diagnosis were rather unlikely. He was managed with withdrawal of the oral dexamethasone 6 milligrams started the previous day in consultation with the physician in charge, and was put on observation and counseled about his condition. The patient was discharged when stable as per protocol after 2 days with recommended follow-up at 3 weeks. However, he reported to us at 5 weeks. At this time, in our OPD, the visual acuity in the right eye was 6/9. The PEDs were as before, but the central serous retinopathy, the serous detachment in the right eye had enlarged. The OCT macula corroborated our findings, and the neurosensory detachment was seen with the exudative material. Choroidal pachyvessels were noticed beneath the neurosensory detachment. This is the left eye OCT. Assessment in the post-COVID OPD using DAS-21 questionnaire revealed a score of 14 corresponding to moderate anxiety. Observation with counseling by a psychologist led to resolution of his condition at 6 weeks follow-up. Further follow-up could not be obtained due to the ongoing pandemic. The presumed pathogenesis of CSCR is choroidal ischemia and increased capillary permeability. There are only a few incidents of PCSD in patients admitted in hospitals for COVID reported in literature. Acute CSCR may have been precipitated by corticosteroids, but only 1 dose of dexamethasone was given. So the role of endogenous steroids, the stress of hospitalization, in addition to the psychological burden, cannot be ruled out. It is possible that the development of pachyvessels was due to choroidal ischemia, which is similar to the study of Savastano et al. In the peripapillary capillary plexus. Hence, this is a case of pachychoroid spectrum disorder. Personality assessment and counseling may be included as part of COVID care to mitigate the risk of visual complications. The alteration in choroidal perfusion due to COVID-19 may contribute to the development of pachyvessels, underlying the pathogenesis of CSCR in these cases, which is an area of further research. Thank you.